Hi, my name is Mike Hartman, and I'm an oral surgeon in private practice in central Pennsylvania. I've been using X-Guide now for about the last 4 or 5 years, and I've been able to incorporate the use of X-Guide in probably 99% of my dental implant surgeries. I'm a big fan, a huge believer in the technology and the accuracy that it gives a surgeon placing dental implants. In about a year or two, I started to look into the ability of the technology to help us start to make immediate provisional options for our X-Guide plans. And kind of as an offshoot of that, I started a dental laboratory and hired a full-time lab technician. And we've been able to develop some unique workflows and provide ourselves as well as some of our clients with immediate provisional options. So kind of the point of the webinar today is to share with you some of the workflows that we've been able to develop, and also how when you combine the technology like X-Guide with a laboratory like our laboratory, digital provisionalization technologies, it can help the user improve their patient outcomes in an even timelier and more efficient manner. I think sometimes we lose track of why we do immediate provisionals in the first place, and obviously patients like them because it gives them an option that is fixed, and it's something that's not removable, like an Essex retainer or a flipper, and that makes it more convenient for the patient. Now, aesthetically, they're not quite as good as the final restoration will be, and they always have to be slightly out of occlusion also, and we have to tell our patients that before we're doing the surgery so that they have realistic expectations of the provisional restoration. But if you look at this article here that I pulled to share with you today, the actual main benefit of provisionalization or immediate provisionalization is the contouring or the ability to maintain that soft tissue profile around the implant so that the final restoration will be aesthetic and hygienic. And this is a study that Dr. Chu and his colleagues did a few years ago, where they had 4 groups for immediate implant placement. The first group, they placed a stock healing abutment with no bone graft. The second group, they placed an immediate provisional with no bone graft. The third group received a stock healing cap with a bone graft. And the fourth group received an immediate provisional along with a bone graft. And when they analyzed the results, they found that Group D, the one that received the provisional with bone graft, had the greatest amount of peri-implant soft tissue height and thickness in the facial palatal direction. So in my opinion, that's what we're really trying to achieve with some sort of provisionalization. We want to be able to capture that soft tissue thickness so that it is present for final restoration. And my main goal in provisionalizing or placing custom healing caps is I want to speed up or perhaps even eliminate a further provisional phase that the restoring doctor is going to have to do before the patient is ready for their final restoration. And when we're able to do this, we can achieve soft tissue results like this at the 3-month mark after our implant placement. And this is a great service that we can provide for our patients. And this is also something that our restoring doctors notice. And this helps us differentiate our practice from others in our area. So when we're thinking about performing a immediate extraction, immediate provisionalization, it's always important to develop some sort of criteria for a successful case completion. And this is an article that was done several years ago, and I like it in that it breaks down criteria into surgical criteria and provisional criteria. Now, there are numerous other well-written articles out there on criteria for immediate provisionalization, and they may vary from this article, and that's fine. As long as you're comfortable with some sort of criteria, you can use that when evaluating your cases with your X-Guide virtual treatment plan, and I'll share that with you here in a couple slides. So if we look at this article in particular, their surgical criteria mentioned minimum insertion torque of 15 Newton centimeters. They wanted their implants 3 millimeters apical to the extraction socket, and they wanted their implants at least 1 millimeter placed inside the facial plate. Their provisional criteria was that the provisional be placed within 3 days after the procedure, and that the provisional was able to support the adjacent papilla in the gingival margin. For those of you who aren't familiar with X-Guide, it is a form of dynamic navigation that allows us to place our implants in an accurate manner. There's tracker arms that are attached to the patient. There's a tracker arm that is attached to your surgical handpiece. These tracker bulbs are read by an overhead camera, which relates that information back to the computer, and the computer then processes that information and displays it onto the display monitor. This is a screenshot of the X-Guide monitor. You can see that we have the patient's preloaded cone beam CT scan. The blue rectangle is our proposed virtual treatment plan or virtual implant placement. We have a shot of our drill bit where it's at in relation to the CBCT. That upper left-hand screen is the giant bullseye, if you will, and basically the surgeon watches the display monitor to perform the osteotomies and also to place the implant in the correct position. So we can use this technology to help us assess surgical criteria for an immediate provisional case. One of the questions that I had about X-Guide before I purchased it was does it work? And I think that's important when we're assessing any sort of new technology that we're thinking about implementing and investing in our office. And there's several well-done studies out there to support the accuracy of X-Guide. This is one that I like in particular, and this was done several years ago. The reason I like it is because there were 4 different surgeons that participated in this study. And what they did was they analyzed their accuracy of their dental implant placements when they were placed with dynamic navigation or X-Guide versus when they were placed freehand or the more traditional manner. Now, these surgeons placed a little over 200 implants with dynamic navigation. And when they did their accuracy assessments, one of the things they looked at was their angle of deviation. If you look at this cartoon that I drew to illustrate the points of the article, the navigated group had an average degree of deviation of 3 degrees versus the freehand group, which had a 7-degree deviation. And you may not think that 4 degrees is a lot of additional deviation, but if you think about it in terms of a buccal lingual deviation, when you're planning out, say, a molar implant, if you're tipping that additional 4 degrees, you're probably going to be tipping or putting your screw access hole or path of insertion, if you will, through the facial cusp of that tooth. Now, that's not a huge deal, but the restoring dentist and their restoring technician are probably going to have to restore that with a cement retain restoration. I don't really dictate to my referrals how they restore their restorations. I think that they are in tune and savvy enough to do that, and they are certainly the experts in that. But I feel like my job is to give them options. So when I place dental implants, and if you think about it from the Restorely driven treatment planning aspect, I want to be able to give my referrals options. So I want to be within that 3-degree sphere of deviation so that they have the ability to restore that dental implant with a screw retain restoration or perhaps a cement retain restoration. At least they have options to do that. This was some accuracy assessments that I did on some of my cases to see if I was able to navigate within that degree of deviation that was quoted in the previous slide that I just shared with you. And if you notice the date of these surgeries, this was about 3.5 years ago, and this was about 6 months, after I had purchased my X-Guide. This was 2 patients where I'd placed multiple implants on, and my angular deviations, even at that time, were fairly consistent with what was quoted in that article. And there's some other things that you have to consider with accuracy. Remember, your implant is going to deviate in a global position from your planned implant in terms of a mesial distal buccolingual manner. And I put this cartoon down below to kind of help illustrate that, because it's important to start thinking in terms of accuracy in an X, Y, and Z axis, especially when you're considering placing immediate provisionals, because we want to be as accurate as we can, not only in our degree of deviation, but also in our global position. And I will tell you, the position that varies the most typically for me is your depth, because that a lot of times is something that you're sort of clinically seeding at the time of implant placement. And what I found over the years is I've become probably a more precise planner in terms of my virtual treatment plan, because I want my virtual treatment plan to correlate exactly with my surgical plan, because that gives me the greatest ability then to seat or insert these immediate type provisional fixtures, which we'll look at here in a couple minutes. The provisional criteria, I think, for that article that I shared, that the bar was set kind of low, in my opinion, in terms of an acceptable outcome. And sort of thinking through this process and workflow when we were developing our techniques, I kind of came up with what I considered an ideal criteria for provisionalization. And I don't want to be able to seat my provisional within 3 days, because that means that the patient's going to have to come back for a follow-up appointment, whether that be with the implant surgeon or with that patient's restoring doctor. I value my patient's time a little bit more. I want to be able to do this successfully in one appointment for them. So in my ideal criteria, I feel it's a must that we insert the provisional at the time of surgery. And I don't want that provisional to be made chair side. I want that provisional to be lab processed and smooth to ensure that the best quality. I want it as aesthetic as it can be, and remember, this is a provisional. Our materials options, the shades and so forth, are a bit limited compared to final restorations. And remember that these, if you're planning to do an anterior tooth, a lot of times the incisal edge is going to flare a little bit. It's going to be a little bit shorter than the adjacent tooth. And these are things, remember, we have to set realistic expectations with our patients about prior to surgery. And I don't want to spend a lot of time at the time of surgery adjusting it. Ideally, in my mind, I would love to insert the implant, literally screw on the provisional, check the bite, seal up the access hole, and the patient's done. And sometimes, I will tell you, it's kind of like that perfect golf shot sometimes that you have. If you have a real nice drive, it kind of keeps you coming back for more, so to speak. And occasionally, we'll hit it out of the ballpark with provisionals where we literally just insert it and check the bite, and then we're done. In terms of a preoperative workup for these cases, it's a standard sort of X-Guide workup, if you will. We see our patients 2 weeks prior to the proposed surgery, where my assistant will mold and form a X-clip onto the adjacent side of the patient's dentition of the expected surgery. We will also acquire an intraoral scan of at least the surrounding area and the adjacent teeth. If we're planning to do, say, a backup Essex retainer or some other sort of provisional, then we'll go ahead and scan the entire arch. My assistant also happens to be a part-time wedding photographer, which comes in very handy for photo documentation. And we try to do a pretty good job of documenting our work too. I've found over the years that no matter how great I think a case is completed, when I go back to the photos and review, there's always room for improvement, and that's what I think makes our job so exciting. There's as good as we can do, there's always the ability to improve. At least for me, there is. Once we acquire that CT scan and our intraoral scan, we upload or we create a new case in the X-Guide virtual treatment plan, and now we have aligned or mesh our intraoral scan over our CBCT scan. We've gone ahead and virtually placed our implant into the position that we feel will be the most restoratively driven, if you will. And what's nice about X-Guide is there's no implant libraries that we need to worry about. It doesn't matter what implant system you use, you plan your implant in a generic fashion. So you basically planning it by the diameter of your implant as well as the length. If we overlay Dr. Jensen's surgical criteria for immediate provisionalization, we have 2 of those 3 points checked off just by virtue of our virtual treatment plan. We have sufficient or adequate apical bone for primary insertion of our implant, and we're able to measure and ensure that our implant is placed far enough off the facial plate. All we really need to do, if we navigate an accurate plan at the time of surgery, is to evaluate and assess whether or not we have the minimum insertion torque that we're comfortable with placing immediate provisionalization. In terms of how this workflow works with our laboratory digital provisionalization, it's very easy. The X-Guide software, if you click on that file button on the upper left, the drop-down box gives you the option to export your plan data. So you're going to go ahead and click on that button, which is going to bring up another screen here with a couple more options. And if we enlarge this, we need to export the implants. We need to export the maxillary intraoral scan. We're also going to need the mandibular opposing intraoral scan, because remember, we're going to set this provisional, check its bite with our dental CAD/CAM software that we're using. We are able to put that on a virtual articulator to make sure that there's no excursive movements or contacts. And we are doing this because we want the procedure to go as smoothly as possible for our patient. Once we ensure that all of the appropriate boxes are checked, then we're going to go ahead and click Export Merged Items. And that is going to export your plan out in one file. And typically this file is going to have the patient's name, which I blurred out, a bunch of letters and numbers, and then it's going to say the merge underscore STLs. And that is going to ensure that you have exported your plan in an appropriate fashion for our lab to go ahead and process and design and fabricate the provisional options. Once you have that file, then it's very easy through our website. There's a button at the top that says upload your plan. That brings you to our HIPAA secure upload portal, where you're able to enter the patient demographics and pick your shade and so forth. And then you can also attach your X-Guide files to upload to our laboratory. Once in the laboratory, we are able to take the merged STLs that you sent us. Brett, our technician, then transfers those into a implant, if you will, in the software. We place a tie base and then build the provisional on top of that, just as if basically he were designing a final restoration. For those of you who have talked to Brett on the phone but I've never seen him, I thought it'd be nice to put a face with the name. And well, this is Brett. This is a picture of Brett from our 4th of July hot dog eating contest we had this summer. We thought with the pandemic we needed a little bit of levity in our life, so Brett was kind enough to step up to the plate to be one of our participants. Rather poor showing, but there's always next year, I suppose. So anyway, Brett then fabricates the provisional, and this is basically what we send back to you, and this is what you have prior to your surgery starting. At the time of surgery, then we're going to extract our tooth and navigate our dental implant in the correct position using our X guide, and then we go ahead and insert the provisional. And this was a real case that we did, and turned out very nicely. There you see pretty decent aesthetic results, pretty good anatomy of the provisional, and the patient was very happy with this, and this was a great service that we were able to do for her, and she really appreciated it. So now let's go back to the provisional criteria again and look at our ideal criteria, and you can see that I've checked off pretty much all those points that I've wanted to accomplish with an immediate provisional. In terms of a minimal additional chairside, obviously this varies from case to case, but it does tend to be minimal. And if we look at my operative record from the case that we just went through, if you look at the procedure start and end times, I was 47 minutes from the time of start to the time of finish. So I was able to extract, place, and insert in under an hour. And typically 60 minutes is what I like to be under 60 minutes for these cases. And a lot of times we're able to do that. It's always nice to have peer validation when you're implementing new techniques and new workflows, and I was motivated, if you will, to write up this technique and have a case well documented and submit it to the Journal of Prosthetic Dentistry, and I was fortunate enough to have this published in last January's issue. So that's nice to have sort of peer validation for a new process that helps me at least know that I'm working in the right directions. Probably more important though is it's nice to have patient recognition that you're doing nice things. And the case that I just showed there, that immediate on number 12, after we completed it, the patient took the time out of her busy schedule to write us a very nice Facebook recommendation. And basically, in essence, what she wrote, I think I was trying to capture in terms of our practice culture, and I thought it was great. I thought it was short and succinct and to the point. And we are currently revamping our website, and one of the big questions was, what do we use as our main sort of area or main picture on our homepage? And I think that patient's quote actually says it all, and I want to be able to differentiate my practice from others, so we use it. Let me show you a couple case examples here and kind of point out some pearls that I've learned along the way. I'm typically comfortable now provisionalizing on the maxilla from first premolar to first premolar. Sometimes we'll do some lowers. In fact, 2 days ago we did our first lower first premolar, which worked out fine. If you're considering adopting this technique or starting to use this immediate provisional, my recommendation is probably to start with a first premolar. They have pretty wide contacts. You typically have a lot of apical bone to get good primary insertion, and in my hands they tend to be the most straightforward provisionals to do. So probably a good warm-up case, if you will. If you jump forward in the arch to the canines, still not too bad to do. Just remember you have to check those excursive movements to make sure that there's no contact. If we highlight the case down here on the bottom of the screen, in terms of assessing whether or not this technique works, it's kind of hard to tell. I suppose we could check our accuracy analysis of our virtual treatment plan versus our real surgery to see if we were close. I kind of like to assess myself on provisional cases by looking at my screw access hole or path of insertion. As long as my path of insertion is lining up with my screw access hole, and as long as the provisional goes in easily at the time of surgery, then I'm happy. And typically I will tell you this is how it goes, probably 95% of the time. The canine on the upper left, probably not the greatest photo ever, but this was sort of a unique or special case, and it was something that I felt very good about. This was a patient that was involved in a motorcycle accident. She was very lucky that she really only chipped a couple of her front teeth, fractured this canine off at the gum line, and sustained a pretty big through and through laceration of the lower lip. The dentist at this point had already put provisional crowns on the 4 front teeth, and the patient was very aesthetically oriented. I wasn't sure what we were going to do in terms of a provisional option if we needed to do something removable. I felt like the Essex was going to pop off those crowns, and I wasn't happy with the flipper sitting over the healing abutment of the implant. So I was really trying to set this case up for success by doing an immediate provisional. Due to the laceration that was starting to heal on her lip, she had very limited mouth opening, and we weren't able to insert a X-clip comfortably at our preoperative workup like we normally do. Luckily, X-Guides come out with their amazing, in my opinion, X-Mark technology here in the spring that we were able to use now. And for those of you who aren't familiar with that, X-Mark is basically fiducial-free navigation. You're able to seat somehow the tracker bulb or the tracker arm mount onto the jaw that you're navigating, and then you're picking up points at the time of surgery with a probe. And once you're picking up those points, the Surfix technology of the software is able to calibrate everything so that you can accurately navigate your plan. And that's was what we had done here for this case. For those of you who are starting to use X-Mark, my advice is spread out your points as far as you can in the arch. I'm left-handed, so I'll try to keep that tracker arm on the right-hand side. So for this case, we picked points, the canine on the right, the premolar and molar on the left-hand side, and we're placing our clip or our mount on the right-hand side. And I usually pick the cusp tips. Try to pick teeth that are not heavily restored. They tend to be the easiest then to identify and calibrate at the time of surgery. And this is a case that I shared on the X-Guide Dynamic Navigation Users Group a few weeks ago, and this is a good group to be a part of if you're using X-Guide now or considering using it. There's a lot of good practitioners on there that share some of the tips that they've kind of found workarounds or solutions to. If we jump forward to lateral incisors, in my opinion, I think these are the toughest provisionals. There's not a lot of room for error. The tie base that the provisional sits on tends to be fairly wide, and the provisional material that comes down over the neck of the tie base tends to be very thin. And sometimes we'll see some flexure in this area that occasionally makes it prone to breakage. What I've been doing here lately is we will intentionally bulk up that cingulum or neck area on the provisional, and after I place the implant, then I'll take a round burr, and if I have the space, then just sort of ferrule the bone around that implant platform a little bit wider, because we want to ensure a little bit of extra strength in that area, because it is a flexure point. Remember, it's a provisional material. It's not meant to be there for a super long time. Central incisors, I think, go pretty good. The bottom picture is a picture of a case that our new associate, Dr. Sibley, had done, and Dr. Sibley's started in January. COVID kind of slowed him down with X-Guide. He's been up and running since then, and Dave's about 3 months in the X-Guide now, and he did his first immediate provisional case a couple weeks ago that went very well. So it is something that you are able to do even if you are new to the technology. Do not feel like you have to have done thousands of these cases to be able to implement this workflow. If I draw your attention to the provisional on the upper left, what's really awesome in the software now, that one of their updates that they've done recently is they give you the ability to angle your path of insertion or place an angled abutment onto your planned implant. And in a case like this, in the anteriors, you can see our initial path of insertion is coming out through that incisal edge, and that's typically something that's kind of hard to look good or hard to temporize at the time of insertion. So if we place an angled abutment on there of 8 degrees, that's bringing back our screw access hole through the cingulum of the tooth. And we have the ability to use angled screw channel abutments to fabricate our provisional restorations. And this is, again, this leads to a little bit easier time, reduces the amount of chairside time that you need to do by sealing off the screw access hole, and it gives your patients a better aesthetic result at the same time. My only kind of pearl with this is if you're planning a case that uses an angled screw channel, remember that these ASCs oftentimes need the screws themselves are different, and you need a special driver. The driver usually has a ball on the end of it with the flutes, so make sure that you have this prior to your surgery so that when you're placing the angled screw channel abutment that you don't get frustrated and have the right tools in order to insert that. We can do 3-unit bridges. We tend to do these more in the traditional manner still. We'll go ahead and design the 3-unit with wings on it, and I'll still place temp cylinders on my implants and pick those up at the time of surgery. This is a good tip that Brett, my technician, taught me. Sometimes your temp cylinders deviate a little bit too much, and it's hard to insert the provisional over top the temp cylinders. So if you take one of the temp cylinders out, seat the provisional, and then reinsert that second temp cylinder, it prevents you from having to significantly widen that access hole. Kind of saves a lot of the integrity then of the temporary bridge. And that's exactly what I'm doing here, sort of inserting that second temp cylinder, and then once the cylinders are down, then we'll go ahead and pick those up. We'll take that out then and finish it outside the mouth, and we get a very nice aesthetic result for the patient, and a fairly decent amount of time. It didn't really take it too much more time to do this. As always, I tell my patients, hey, we're planning to do a provisional here. If we can't meet our criteria, then we're going to have like a removable provisional, such as an Essex. And remember, at the end of the day, I still want to capture or start to contour soft tissue for the final restoration. So we will typically fabricate also a custom healing abutment for these cases as our backup plan, because I still want to be able to deliver the best possible final restoration, regardless of whether or not I can do an immediate provisional or not. And this is another great tool or product you can use to help differentiate your practice. These custom healing abutments are fabricated out of a tie base with some printed acrylic resin around there. I typically like to use pink. I think it blends into the gum tissue. It doesn't catch my eye or the patient's eye. The acrylic is soft enough that it's easily adjusted with an acrylic burr, and we're still preserving our soft tissue profile, and we're getting a nice result. And if you're looking at the undersurface of these custom healing abutments at the time of your 3-month post-implant evaluation, you can see that they stay fairly clean, and they have a fairly benign tissue response to the underlying peri-implant mucosa. And this is something that does catch the attention of your restoring doctors. And these are, one example of kind of nice text messages that I like to get on our post-operative patients. And your referrals will know the difference, and they will start to seek your services out more frequently, especially in higher aesthetic demanding cases. As much as the custom healing abutments do to help contour aesthetic results in the anterior, I think their true workhorse ability, in my opinion, is in posterior immediate implant placements. Since I got my X-Guide, I try to place immediate molars as often as I can. I think the technology is great. I think it's a great service to the patient, again, that we're able to speed up their time from extraction to restoration to 3 months, as opposed to waiting for a bone graft to mature and then placing the implant. The custom healing abutment does a great job of preserving the gingival architecture, but as you can see in this picture, it also does a great job of acting as your graft containment device. I usually don't even put sutures. I don't advance flaps normally. I'll go ahead and perform the osteotomies with the X-Guide, insert the implant. We will densely pack the bone graft around the implant, and then we'll simply screw on the custom healing abutment, and we're done. And this is, again, something that our clients have done. It's very nice when they take the time to send us nice photos of the soft tissue results that they're getting for their patients also. Probably the big question that came up during the X-Guide Users Forum last year was, what about full arch immediate load for X-Guide? And kind of how I thought through ideal criteria for single unit provisionalizations is kind of been thinking through ideal criteria for full arch immediate load. Me personally, I want to be able to complete these procedures in a single appointment, and I want an efficient workflow. I want an aesthetic outcome for the patient, and I want to be able to do this basically without the assistance from my referring doctor, and I feel like I want to respect my referring doctor's time. We both have offices that we have chair time to fill, and if my restoring doctor is over in my office watching me for 2-3 hours performing implant surgery, that's valuable chair time that he's not able to utilize in his office. So I think close collaboration and close planning prior to the surgery is very, very important, so that we are able to accomplish what the restoring doctor wants us to accomplish. But in regards to the actual surgery, I feel like, especially with digital technology and all the advancements and techniques that are now available to us, I think the surgeon should be able to do these cases by his or herself. The system needs to be intuitive. There can't be a million parts and pieces and sort of confusing things that may lead to error during the surgery. And probably most importantly to our patients is it has to be affordable. And we have an affordable option, then this opens up this treatment to more of our patient base. The X-Guide software certainly gives us the ability to plan out for a full arch case, because we are able to plan on angled abutments. One of the challenges that I've come across is how do we mount this patient tracker arm so that the tracker bulb is in the right position. And there are some commercially available products now that certainly work, but I felt like there may be a better option, especially when we're going to be performing such a big case like this. So with that in mind, I developed a new system called the X-Static system, and I named it X-Static because I feel like it takes advantage of the best that X-Guide has to offer, and also some of the probably advantages that Aesthetic Guide has to offer for these cases. This is a picture of an overlay of an Ecstatic Guide onto that full arch case. We've designed it that it has a occlusal positioning device to mount the foundation guide, if you will. And what's great about this foundation guide is it only fixates onto the buccal aspect of the patient bone. I will tell you it's very accurate. It adapts very, very closely. Once we seat it in the proper position, then we fix this guide into the bone with screws, and we ensure that those screws are bicortical in nature, so that it's a strong mount. There's no chance basically that this mount is going to dislodge during your surgery. And we also are able to design these screw placements around where the proposed dental implants are going, so there's no chance that there'll be any sort of collision or interference at the time of surgery. Once it's fixated in place, the occlusal positioning device is removed, and then we go ahead and reduce our bone, and we plan the foundation guide as also to be used as a bone reduction guide there too. It makes your reduction very efficient and very, very easy to do. And then once you're at your reduction level, you navigate your implants in the correct position. And then even at that point, then you're able to use the attachment portions that seated the occlusal positioning device, and you're able to mount your immediate hybrid on those same mounts. And we've had some beta testers use this technology, and it's very intuitive to use, and it's gone very smoothly for us. And for those of you out there that are used to using these sort of immediate load options that are available for true static guide systems, you now have the ability to utilize the same concept, only instead of using the surgical guides that require the long drills and can become cumbersome and everything at the time of surgery. Now you have the ability or the advantage to place your implants with dynamic navigation using your normal drill bits, but then at the same time you have a solid foundation on which to stack your immediate hybrid, which you can then easily pick up in the mouth, remove, and finish outside the mouth and insert. And this may save you time over the more traditional manner of converting a denture at the time of surgery. So if you think about it, in my opinion, what was really missing with X-Guide was that kind of combination of a dental laboratory that really wanted to just focus on provisional options for these X-Guide cases, because I think it's important to kind of focus on what you're good at, and that's sort of our mission here, our goal at Digital Provisionalization. We use X-Guide all the time. Brett works very closely with me. We're able to move on technology and workflow and develop new techniques rather quickly. If there's issues that pop up at surgery, we're able to address those at the same time and make corrections rather quickly. And now our workflows are to the point where we're able to share these with other X-Guide users. It's such a great system. It's very seamless workflow. It's very easy to upload your plan to DPT so that we can assess and design and fabricate what we need to do. You will definitely improve your patient outcomes, especially your soft tissue outcomes, and it really does help you differentiate your practice from other. And what's also great about the fact that X-Guide gives you the ability to plan your implants in a generic fashion, we, as the dental laboratory, have the ability to plan your cases on any implant system that you use. We're not locked into one sort of proprietary system. We're able to use whatever implant system you're comfortable with, which I think is great, the fact that there's such open architecture in the system that we're able to do this. And with that, I'd like to say thank you for your time and watching the webinar. I hope you pick up at least a couple pearls there. Stay tuned. There will be a live Q&A session with Chris Scharf and X-Guide here in the next week or two. We haven't exactly nailed down a date, but we'll make you aware of that, and look forward to answering your questions at that time. Thanks.